Welcome, everyone, and thank you for joining us for today's webinar on increasing your CMS telehealth reimbursements, sponsored by Diagnose. I am Maggie Moran with Becker's Hospital Review. For our program today, we will first begin with a presentation, and then we will have time at the end of the hour for a question and answer session. Please submit any questions you have throughout the presentation by typing them into your control panel. You'll see a space labeled "Enter a question for staff," and you can click send from there. We are looking forward to hearing your questions. We would also like to let you know that today's session is being recorded and it will be available after today's live stream. In about a week following the webinar, you can expect a copy of the presentation sent to the email that you used to register. It's now my pleasure to start today's webinar by turning the floor over to Dave Wortman, CEO and co-founder of Diagnose, to kick off today's discussion. So Dave, I'll hand it over to you.
Thank you so much, and good afternoon, everybody. Thank you for joining us and taking time out of what I'm sure is a very busy day for everybody. We're excited about the topic, excited about the panelists that we've been able to assemble, and let me begin by making some introductions. I am Dave Wortman. I am the CEO and co-founder of Diagnose. I've been a technology entrepreneur my entire career, developing solutions to important problems in a variety of industries, including healthcare. My work has centered around building enterprise-grade software systems that were designed to streamline and automate complex business processes. At Diagnose, we're applying these concepts to healthcare communication, and while I'm sure you would all agree there are many obstacles to overcome, the future for both healthcare professionals and patients everywhere is indeed bright. Next up, Dr. Mike Fletcher. Dr. Fletcher is Vice President and Chief Medical Officer of Hancock Regional in Greenfield, Indiana. He's been with Hancock for more than 30 years and has served as Hancock's Chief Medical Officer since 2004. Also joining us is Gene Scallon. Gene is the Vice President of Network Development and Innovation for Springstone Health, a behavioral health services organization headquartered in Louisville, Kentucky. They have 17 inpatient and 35 outpatient facilities throughout the country. She's on the board and also chairs the Indiana Hospital Association's Behavioral Health Council, and she is a Zero Suicide faculty member. And Marty Ross is also joining us today. Marty's an attorney and principal at PYA, a professional services firm specializing in healthcare consulting. Marty has a depth of experience as a healthcare transactional and regulatory attorney, and she leads the Value Transformation Practice Group for PYA, based in Kansas City. She applies her knowledge of new payment and delivery systems and public payer initiatives to help providers strategically position their organizations for the future. So we'll dive right in, and I have a few comments to make, and then I'm going to turn things over to our panelists. As I'm sure you'll agree, all of us are in the midst of a massive transition, not just in the technology we use, but in the way we live our lives. We live in a virtual world. Our connections with each other have been extended beyond our four walls. We connect virtually in every day and in every way, not as a replacement for in-person interaction, but truly as an extension of it. It's making our lives better in so many ways, and it's become so ingrained that we even have changed our language. We don't call it teleworking, we just call it work. We don't call it teletravel, it's just travel. And we certainly don't call it teleshopping. It is just shopping, and we hope everything gets delivered in 2 days. So what about healthcare? Well, in our view, the same approach that we use in other aspects of our lives will come to be used in healthcare too, and we will eliminate the notion of telehealth and call it for what it is rapidly becoming. It is just healthcare. Our mission at Diagnose is simple. We deliver communication tools that reflect the natural habits of healthcare professionals and patients. We believe as we're successful, everybody benefits. Quality of care goes up, costs go down, satisfaction improves. And success is predicated on that notion of natural habits. We need to fit into the way that all of us communicate. So what does that mean? Well, it means everybody who's involved in the delivery of care should be connected, clinicians, staff, and patients. It means we should have control of what channel of communication we choose to use, be it video or voice or text. It means we should easily be able to share data with one another, directly from the EHR as well as from other sources. We should be able to communicate not only within our organizations, but across organizational boundaries with our partners and affiliates. And of course, it means we should be able to do all that with a single cloud-based platform. So let me finish by suggesting that DiagNotes fits well, and in fact, at the intersection of healthcare workflows and personal communication behaviors. We want to close the gap with a broad range of modern and familiar tools that extend the clinician's reach and save time, that promotes proactive healthcare and better outcomes, and that all can happen in a way that is quick and direct, empowering everybody to live healthier lives with easier access to care. So with that as a backdrop, let me introduce you once again to Dr. Mike Fletcher, VP and Chief Medical Officer at Hancock Health and Hancock Regional Hospital. Mike, it's all yours.
Thanks, Dave, and welcome, everyone. Just a little bit more about my background. I'm an internist, and I've practiced traditional internal medicine, both office and hospital, for probably about 25 years, and now I just do a little bit of primary care, so I'm able to still utilize some of these tools. I'm also responsible for the hospital's program, but I want to kind of take you through our journey as we've implemented DiagNotes to try to enhance clinical communication to achieve some of the things that Dave talked about. So we're from Hancock Health, and we're out about 15 miles east of Greenfield, Indiana. We're a small 69-bed acute care hospital. We have a full 24/7 hospitalist program, about 24,000 ED visits and over 3,000 admissions. We own our own home health service and hospice, and also have a state-of-the-art oncology center and interventional cardiac cath lab. We also use Meditech as an electronic record, both in our hospital and in the offices as well. Dave, you go ahead and change the slides. Okay, so one of the things that we've done traditionally, back probably in the 2000s, we used to communicate quite a bit with alphanumeric texting. We'd send a lot of clinical information, and then about 2009, when the HITECH Act was passed, and then later in 2013, when the HIPAA final rule came on board, we really obviously could not do that anymore. There were penalties for communicating PHI that way, so we really ended up having kind of a lapse in our ability to effectively communicate, just the simple things we were doing with that. We then studied the situation and identified a number of areas of clinical communication that we thought had gaps and were opportunities to do things better. We also undertook a bit of a study with one of our hospitalists who basically kept track of how many times, and I use the word interruption, but I don't really like that word. I would say had their focus altered while they were doing something by an individual who would walk up to them or who would call them. And basically about 6.3 times an hour, or about every 9.5 minutes, they had their attention diverted. And so there's good studies that show when a clinician, nurse, or physician interrupts their focus on something, there's an increased risk of making an error or forgetting what you were doing. So if you multiply that times about 8 hours, you can see the number of times that a clinician's physician was interrupted. And the other thing we identified during that study was that about 60% of those interruptions in their focus were non-urgent, so could have been communicated in a different way. And so that led us to pull a group together and try to find a solution that we thought would help solve this problem as well as the many gaps in communication. And so through that process, we actually decided to take on, our solution was to, Dave, you can go ahead and move that slide. Yeah. So basically, we decided through a team that we were going to use a digital platform for communication. And so, like any other implementation of something that was new technology, there were a lot of challenges you faced. First of all, everyone said, well, that's an IT project, and so there was a conversation about whether IT should lead this. There was also competition with all the other priorities that the IT staff had, around EHR and other things. There was concerns about complications, expense, and also the physicians being too resistant. But one of the things that we ended up doing, which I think really made a big difference, is that we were actually able to have this being led by the physicians, by medical staff services. So my department led this, and really we did not, we partnered with IT in the areas we needed to. They gave us access to Active Directory, but our team here basically led the entire implementation of this project, and so it actually went very well. We worked closely with the team at Diagnotes, but we were able to implement this ourselves, and it made it much easier. And I think the acceptance was much greater coming from our medical staff services leadership versus from an IT project. And one of the interesting things that happened to us just about a year ago this month, our hospital was a victim of a cyber attack. And so we, our entire system became, we were attacked, we shut down our entire system. And with that, we lost our phones, we lost our ability to communicate. And so one of the things we did is we rapidly added those who were not on Diagnotes to their phones so that we had the ability to communicate with each other internally and even somewhat externally using our Diagnotes system during that crisis. And as you can see by the headline, we actually paid $55,000 in ransom, and we were literally back up and running in about 4 or 5 days. And if anybody has any interest, you can Google that, and there's a ton of information written. We were very, very transparent about how we handled that, and there's a lot of very interesting information that you can learn about. And I hope it never happens to any of you. Through our process here, then. Okay, so we really have now been about 3 years into our implementation of Diagnotes. We have most of our physicians who see patients in the hospital and in the clinical offices locally up on it right now. Have a few who have not yet adopted it yet. Many of our departments in the hospital are utilizing this as well, and we've really found that there's significant improvement in a lot of the workflows when it comes to communication, either from one individual to another or pulling in multiple people at the same time. There's also our switchboard operator uses this for on-call, and so the ability to communicate necessary information really helps there as well. And the other thing that's really significant is that you can get a confirmation that the recipient has read the message, so whoever sent it knows that it's been received and that it's being processed, versus the old days of wondering whether that page has been received since they haven't called back yet. We also are seeing a significant decrease in texting of clinical information, so that has helped significantly. And then we really have a lot of great stories of satisfaction, both from physicians and our hospice department, and even our department that delivers medical equipment have been highly satisfied with this ability to communicate using PHI and doing it in a very efficient way. One of the things that's been really interesting is that when you take the technology and you deploy it to a new department, and you put it in the hands of very creative clinicians, they come up with amazing ideas. And one of the neat things that we've seen is in our diagnostic imaging that we were in the process of potentially purchasing a new imaging facility for our ultrasonographers who were doing a mammography or doing a follow-up on mammography findings. And I think there was about a $70,000 investment in this new technology, but our technicians actually worked with our radiologists, and so they actually took pictures with Diagnotes of the mammographic images and circled the areas of concern, and then they just sent it to the whole ultrasound tech staff, and that's how they knew where to focus on the respective patients versus having to purchase a new thing. So certainly nothing I would have ever thought about, but in the hands of these technicians, they used creativity and were able to come up with a really neat idea. We have a roadmap. We've basically been doing the communication part of it using voice, using text, using kind of a FaceTime functionality, images, and we're in the process of implementing scheduling, and then we're going to be integrating it with metatext, so data from our EHR can be sent out to physicians based on certain criteria. We also are in the process of designing a pilot to start to do some direct patient communication. We're still trying to work out some of the logistics of that. And we are also looking to start to, when we have that in the hands of patients, and being able to leverage some of the telehealth codes that we're going to be learning about here shortly. So with that, I will turn things over to Jean, and then we'll be available at the end for any questions anybody has.
Great, thank you. It's a pleasure to be able to be these panelists to talk a little bit about Diagnotes and how we have been able to utilize that within some of our behavioral health facilities. We started a pilot in 5 of our hospitals in the month, and we're continuing to put that out. So as you can see here, and as what Dave talked about, we do have 17 behavioral health facilities right now, freestanding psychiatric and substance use facilities across the United States. And we have 29 currently, but 6 in development for our outpatient locations, and right around 4,000 employees. It's a lot of the individuals that are sharing information to make sure that patients are getting excellent care, safe care, and that we are really looking at how we partner with our strategic partnerships. With this pilot, which has been really fun, and when you look at this overview, it has really allowed us to increase that communication with our hospitals and with systems that they're working with. And each of those hospitals, like I said, there's 5 of them, have come up with a different use case in using Diagnotes to make that happen. And one that that has just occurred, which is not on this, is we had an issue where we had a provider who was needing to be off for an extended period of time, and we needed to be able to communicate with that individual and other new providers that we were bringing on so that we could have a good cross communication of care. We actually started that just Sunday. And we had activated 32 users within probably less than 24 hours, and to be able to start the communication. That just tells you how easy this is to use, and how that communication and how people have adopted this technology just in a very short amount of time. We can move to the next slide. So, really some of those factors, and with the behavioral health realm, I don't know that we've really looked at some of the communication times. And what makes some of the freestanding behavioral health unique is we do not have an electronic health record. It's not required. We don't get meaningful use dollars for it. So when you're looking at population health and value-based care, really behavioral health and substance use has been left out because large systems do not have an EHR. Diagnotes has really been able to help us with that communication, and with kind of a hybrid of sorts of a way for us to communicate patient care. So, just like they're talking about with any type of stroke or STEMI patients, our response time to patients when they're calling us, when they're in crisis, whether it's from an emergency room or a family member saying, I need assistance, that if we can respond to them immediately, that's going to help. And we're using Diagnotes with that by sending secure text messages to maybe the provider on call, or to the nursing unit saying, hey, I want you to be prepared that we do have a patient coming in. Nurses sending back to our assessment office saying, hey, I want you to be aware that there's a discharge, so we have a bed open. And those are really very patient-focused and safety-focused. The other is around those multidisciplinary teams. So although we have providers in multiple locations and they're covering multiple shifts, really we're just using a lot of that Diagnotes internally for each system, for each hospital. And what we're hoping to do as we as we develop and grow with this application and adopting, different paths for is to look at, do we have a provider in another location that we can use DiagNotes for to tune in? And we are using that in a couple of different locations. And it's really helped with that communication. We can move individuals through quickly and efficiently and have good information shared. And, like I said, we do not have an EHR. We have a whole lot of paper. And so being able to have some type of technology to be able to really fill that gap is important. The other is, just that cultural influence. There is a tremendous amount of stigma still. We're starting to see less and less around those individuals who are struggling with mental health and substance use issues. And just really being able to meet patients where they're at when they need us most. And it's much like Dave said, we're not providing teletreatment, we're providing treatment. We're not providing video access for communication, we're communicating with each other. This is just the way that we do business. And can we move to the next slide? So really, that focus on efficacy of treatment, just like I said, we want to meet people where they're at when they need us most by connecting that care, by using those inclusive tools like DiagNotes, and that way we can truly integrate that care across the continuum by encouraging that communication. Just yesterday we met with a large system just to talk about how can we communicate better, how can we share information where they have an EHR and we don't. This really does help us to fill that gap. So we're using that on that distant site to send that secure communication, or maybe it's sending a medication list, or maybe it's sending a patient's recent treatment record. It has been able to really fill that gap and do so efficiently, and with putting that patient first. So really just thinking, how do we do this creatively? How do we look at things differently? And that's what's been really fun about this whole pilot, is that every single person has come up with something different. And it's just like Dr. Fletcher talked about, when you put this technology out there and you're able to let people think creatively about this, it really can drive up patient care, and it can also drive down costs. And it's been really fun being able to work with DiagNotes, because I have that ability to be very agile with us, and that's really what we need in healthcare, and especially in behavioral healthcare and substance use care.
Thank you, Jane. And let me turn things over to Marty. And Marty, just cue me when it's time to move the slides.
Great. And it's just a privilege to join you today to talk about some of the reimbursement changes and how it is now promoting the use of technology in interacting directly with patients, interacting with other providers to enhance the care furnished to individuals. So let's start with the first slide. And background on our firm, PYA, we are a healthcare consultancy that assists providers of all stripes enhance their operations and take advantage of new reimbursement opportunities, either traditional fee-for-service reimbursement or now in the movement of value-based care to improve the health of their communities. Next slide. And we need to talk about sort of a fundamental shift in Medicare reimbursement that occurred at the beginning of this year. So you probably didn't notice there was a significant change in how Medicare is approaching the use of technology in the delivery of services. So a fundamental underlying tenet of the Medicare physician fee schedule is that it provides reimbursement for direct face-to-face interaction between a provider and a patient. And traditional Medicare telehealth reimbursement has been centered around the replacement of that face-to-face interaction with a technology solution that connects the provider and an individual at a distant site. And the Social Security Act, which governs Medicare operations, includes a provision that narrowly restricts the use of those telecommunication solutions in delivering face-to-face services. And you'll often hear this referred to as the 1834M rule, for those of you that like to know chapter and verse. But under Medicare's current rules, if you're providing a service that traditionally would be furnished face-to-face, you can deliver that service via telehealth only if the patient is residing in a rural community and they are physically present at the time in a certain type of facility, a hospital, a skilled nursing facility, a physician office. And we have regulations that specifically spell out how you define rural, how you identify these specific facilities at which the patient must be present, and then specific CPT codes that list the types of services that can be delivered and reimbursed via telehealth. Obviously, these rules have restricted the growth of telehealth significantly because it doesn't have the opportunity to expand into urban communities, and importantly, you can't reach the patient at home. So we're not facilitating the delivery of treatment. Beginning this year, however, CMS has finally recognized that there are services now that can be delivered via telecommunication that are not traditional face-to-face services. It's the very fact we have the technology that now allows us to deliver services in a different way. And CMS, beginning in January 1st, 2019, now provides new reimbursement to facilitate that use of technology to improve the delivery of care. And we'll refer to these to avoid confusion as virtual services. So traditional Medicare telehealth is when the technology is taking the place of the face-to-face interaction, but virtual services are when it's the very nature of the communication device, the communication platform that allows the service to be delivered. And we'll begin there. Go back a slide, please, to the remote patient monitoring codes. So this is to facilitate the gathering of data from the patient, delivering that to the provider, and allowing the provider to take action upon that. So let's take a very simple example. We know that heart failure patients, as they're moving to distress, will begin to gain weight because they're retaining water. And so it's a signal that you have a potential issue when you see weight gain. So you can use a remote monitoring device to track patient weight and identify changes in that weight that then necessitate an intervention. That's an example of remote patient monitoring. Now, before these codes became available and for reimbursement, that was just an additional cost that had to be borne by the practice or borne by the patient to provide that level of monitoring to prevent the acute episode. But now with these new codes, we're able to support that technology. First, we have a code, 99453, that focuses on getting the technology to the patient and training the patient. The second code, 99454, is the monthly fee to support that ongoing technology. So having that transmission of data from the patient to the practice. So just the pure infrastructure that's necessary to support that. We have now a code that reimburses on a monthly basis for that cost. And then finally, you have the 99457 code, which is reimbursing the practice's work in retrieving that data, analyzing that data, and then taking action upon that data. And if in the course of a month you devote 20 minutes to providing that level of service, you now have a billable code as well. So first two codes are focused on practice expense. There's no physician work in those two codes. The last code is, in fact, reimbursing for the physician effort involved in remote patient monitoring. Now, I'm sure all of you are ticking questions off on like, well, will this technology work? Or what if I have two different technologies? we don't have answers to those questions yet. CMS published these codes in the final physician fee schedule that was published in November. They promised additional guidance early in 2019, and we're waiting not too patiently to really fill in some of these blanks around remote patient monitoring. But certainly we know the floodgates have opened, that we now have the reimbursement that will enable the use of these really sophisticated technologies to help our patients. Next slide. Now, the second category of virtual services that CMS now provides reimbursement for are virtual check-ins. So this is when the patient calls the physician clinic and says, I have this problem, do I need to come in? And it's typically the interaction with the physician on the phone where they determine that, no, take a couple of aspirin and call me in the morning, for example. It's time spent in the practice. It's time that actually prevents that patient from having to incur the expense of going to the doctor's office. But it leaves the doctor with no reimbursement. Is that it's actually a loss for the practice to take those phone calls, to divert that time from seeing patients and generating office visit revenue. And then it's, to add injury to insult, it's taking that patient out of the queue of a potentially reimbursable event. So CMS says we need to figure out how to address this. We need to create some reimbursement, and that becomes the new virtual check-in reimbursement. They're low volume. They're low reimbursement, but they are intended to be for very quick interactions between the physician and the patient, the staff and the patient, between 5 and 10 minutes. The first code is actually the voice communication or the light communication between the patient and the practice. The second is when the patient submits an asynchronous video or image to assist the physician in responding to particular questions. These codes are intended for established patients only. CMS has indicated in its billing rules that you would have to have patient consent, capture of patient consent, so that because of the potential for the co-payment responsibility for the patient in incurring these virtual check-in expenses. Next slide, please. We'll go to the third type of new virtual reimbursement, which is the interprofessional internet consultation. Not exactly named accurately, but this is trying to now provide reimbursement for those interactions that occur between providers in discussing a particular patient. So when the primary care physician seeks the assistance of a specialist, and the specialist reviews documentation, does research, and responds to that request, that we're now creating a basis for reimbursing that consultation that does not necessitate a face-to-face visit between the patient and the specialist. So we don't have to just go in and do that check-in office visit to create a reimbursement event. Instead, these new codes, and there are 6 of them that are detailed here, now provide a basis for capturing reimbursement for those interactions. Next slide, please. All of these codes are new. All of them will take a period of time for CMS to issue guidance, for the Medicare administrative contractors to issue additional guidance and provide education on them. But we know some basics. These are Medicare physician fee schedule services, which means they need to be billed under a physician billing number. Your site of service for these codes, when you list that on the claim form, are going to be the primary practice location of the physician who is billing for the service. Typically, that's going to be the physician practice or the hospital outpatient department. In terms of completing the reimbursement form, CMS has not issued specific requirements with regard to diagnosis. Certainly, you would want to include the diagnosis that's relevant to the interaction here, but unlike other services that are restricted to patients with certain conditions, these virtual codes are really open to working with your Medicare beneficiaries, and they're not limited to certain types of practitioners. They're, again, intended to facilitate communication, patient to primary care to specialists, and the like. And finally, we have the question of medical record documentation, which is always our challenge when it comes to Medicare reimbursement. Again, looking for additional guidance yet to come from CMS, but we do know, as is typical with any service, you'll be wanting to capture the medical record documentation, the date of service. For those codes that are timed codes, capturing the total amount of time spent with the service, as if possible, start-stop times, which of course is the gold standard for documenting time-based codes. Providing a description of the service that was provided, the type of communication that occurred between the parties, having, as required, some documentation of consent. CMS is not requiring to sign consent form, but just to capture that there was that communication about consent. And finally, of course, having the signature of the individual who furnished the service or was responsible for the provision of the service. Again, we're just starting on these codes now, but we just need to appreciate a whole new set of opportunities and how we can now incorporate technologies like Diagnotes into our processes and generate reimbursement, new reimbursement, that may not make everyone rich, but certainly is going to provide the funding for new infrastructure that improves the quality of care.
All right, well, thank you, Marty, and as well as Dr. Fletcher and Jean. Appreciate your comments. I'm sure our attendees do. Let us move into the segment for Q&A, and we've got questions coming in. Why don't I tee up the first question, and for you, Dr. Fletcher, can you talk a little bit about the challenges associated with adoption of these kinds of new technologies among the medical staff and others, and some of the approaches you've taken and the successes you've had with them?
Yes, so we actually started ours working with physicians directly, and so just like any implementation, you kind of have your early adopters, and you start with that. And when we went live, I think I sent messages to a few and who'd already been set up, and that one of them was on vacation in Florida and sent me a response right away. So that became very easy. And so it really became a matter of, we actually identified an individual who was going to kind of own this, and she kind of became our resource. And so we got the early adopters on, and then there was another group of physicians who really didn't seem very interested, but Becky would then sit down with them one-on-one, or sometimes I would, and just really kind of walk through with them. One of the things that we identified is that almost every specialty has something that means something to them. So a great example would be a cardiologist. You know, we can take a picture of an electrocardiogram and send that to you. Wow, that gets their attention. All of a sudden it gets them on the platform. They start using it, and then other opportunities come from there. We actually have a situation with anesthesia where sometimes they forget to document narcotic usage, and so we put a system in place where our pharmacists will send a Diagnotes message to them about a particular patient where they did not document that. So as soon as they miss documentation, they send it out, it gets taken care of right away. So that was the next step. Then we had a group of, then I really kind of got to a point where I kind of leveraged my relationship to get other people on board, and then there was a group that was really not all that interested, and so I really kind of leaned on those physicians, particularly the hospitals. I said, you know, when you talk to those specialists, you know, encourage them, ask them, you know, to use this as well, and that's been helpful. And then one of the final things that we've done is I've actually asked Diagnotes to develop a new functionality, which I think is going to be helpful, and that is the concept of delayed messaging. So if somebody, 2 a.m. you want to send a message to a surgeon about a consult in the morning, you can send it at 2 a.m., but it doesn't trigger until 6 a.m. And I really think that is going to be highly useful for a number of physicians, and we'll get the rest of those physicians on board.
Well, thanks, Mike. Let me turn to Marty. We've got a number of questions, Marty, about copays and how they apply to virtual services. Can you take a moment and give us some perspective on that?
Yes, CMS in publishing the final rule stated very clearly that all of these virtual services will be subject to standard copayment responsibility. That is the basis for imposing the consent requirement, that because this is not your typical face-to-face visit where the patient would expect a copay, we want them to be aware that these virtual services are now billable services for Medicare, for which they will have their typical copayment responsibility.
That's great. Thank you, Marty. Gene, some questions for you have to do with providing behavioral health services remotely, remote assessments, psychiatric services. Can you fill us in a little bit on how you go about that and what the issues are associated with it?
All right, yeah. Right now, you know, the care is used. We can do tele-assessments, which is a level of care assessment within, we've seen it be successful within colleges and universities. We've seen it being successful in emergency rooms, and being able to utilize technology so that we have that quick response time. It's taking the place of what we used to do years ago, and I think some places still are, which is mobile assessments, where you would get a call out that a behavioral health specialist needed to screen a patient, and you would get in your car and you would drive to the facility, and then you would see the patient. And that takes a lot of time. So we're finding just the use of this technology is that, once again, we can meet the patient where they're at when they need us most and make that quick determination of level of care. I think that's even more important these days because we do want individuals to be triaged quickly so that we can open up care and beds for other patients that are also in need. And we found that to be a very successful model. We see a lot of virtual telehealth services, connected services, really just across the continuum, especially around the behavioral health and substance use space.
Well, thanks, Jane. Marty, I want to turn back to you for a moment. As you might expect, you piqued people's interest with reimbursement-related comments. Can you provide a little bit more information about documentation requirements for the various time-based codes that you identified?
So we have historical practice with regard to time-based codes. Like, for example, critical care is a service that is paid based on time spent with the patient. And what at the end of the day you need is documentation that you met the total time requirement to bill for the particular code. So, for example, in remote patient monitoring, the 5-7 code is going to require 20 minutes of time over the course of a calendar month. So there has to be a vehicle to capture in your documentation that time was spent. Now, most auditors would tell you the gold standard for capturing time is start and stop times. It's not an absolute requirement, but it certainly is going to eliminate any question with regard to total time spent. So it's really a matter, it's going to be with all these codes, is figuring out how to integrate into your processes and as smoothly as possible being able to capture that information and documentation so that it will support the particular claim you intend to submit.
Thanks, Marty. This next one is for Dr. Fletcher. Can you discuss some of the care coordination and communication scenarios that you've seen as delivering the greatest value to the organization?
Yeah, I'd be happy to. And some of these are just my own clinical examples, and I presume there are some clinicians on the line. But, you know, one example, I was in the office one morning and a patient got worked in with some sense of like he was going to pass out. I was overbooked, and so I kind of ran in, saw him, got an EKG on him. It looked like he had some kind of advanced heart block, and so I, you know, kind of while I was talking to him, took a picture of his EKG, stepped out, saw another patient. In the meantime, I sent that EKG to a cardiologist who uses it. He got back with me and said, yeah, I agree with you. And he said, you know, he made arrangements for that patient to be transferred to the heart center. And so I was able to walk back in the room, sit down with the patient, explain to him that I think we had advanced heart block, and we've already communicated with the cardiologist, and literally didn't have to, you know, because I think what we all hate to do in medicine is try to get a hold of a colleague on the phone, because it interrupts our flow. We don't know what they're up to, and it's just disruptive. So I was able to get this patient referred over just in doing that. And the other day, one of my hospitalists had a patient that came in the ED with a gastrointestinal bleed. There was a surgeon, and there was a couple different surgeons involved in the case and a hospitalist, and so he set up a four-way communication to really coordinate early care of that patient. So that was really, I think, quite valuable. And again, communication is the essence of quality care, and that really helped facilitated doing that with multiple clinicians.
Thank you, Mike. This next one, I think I'll direct to Gene, but others may have comments about it. And it has to do with the technology that you're using. And I know, Gene, you've done some experimentation with other technologies. What about the issues of security that you were facing, using company devices, using FaceTime, things of that sort? We've got a number of questions on that in that general area.
So really, you know, it is a big focus, and I think you heard Dr. Fletcher kind of bring this up as well, is that ability. We want to make sure that we're using secure technology in order to communicate PHI, and I don't think that is always used. I think people are so used to just being on their phones and texting, and I know that a few years back I heard that people were using Skype in order to do face-to-face visits with patients, which was not a secure mechanism at the time. And so really making sure that what you're doing is that secure communication, and that's really what Diagnotes has helped us to do, is secure it all within one application, one cloud-based application, so that we can do the pictures and it stays within that Diagnotes app, that we can do that discussion and it stays within that application, and that we can do any pictures or secure texting and it's all within that application. And since people are really pretty savvy around technology, you know, if you look around, people are always have their heads in their phones and spend quite a bit of time there. So you know, it's just really an easily adaptable form of communication, and it does so securely. You know, that's one of the things why we've started this pilot and moved to this, is that people want to communicate quickly, and so they go to that first thing, which is their phone, which is not a secure way to text on their own phone and with their own phone number.
This is Mike. I would second that, and I think the key thing is that none of the information resides on your phone. It's all in the app, and so that reassures some people. And then about a year ago, there was a brief communication from CMS that they were thinking about not permitting PHI communication through these secure devices, and so that led us to a flurry of communications with our legal team, our local law firm, and then we re-accessed the security measures that Diagnotes had put in place, and we re-verified that they met all the standards, and then CMS kind of clarified a little bit. So we're confident through our IT security that their standards are the highest when it comes to IT security. And then the fact that it doesn't reside on the phone, I think, is reassuring as well.
Thank you. And for everybody on the call here, we've got a lot of questions coming in. It's clear we're not going to get to all of them. So please know that we'll make sure you get responses after the webinar is completed. We've got a few minutes left. Let me turn back to Marty and ask or pose a reimbursement related question. We've got a number of them around this general topic. Can you talk a little bit about the costs associated with implementation versus adoption for codes that relate to things like chronic care management and transitional care management? People are curious about how the economics ultimately play out based on your experience working with provider organizations?
It's a great question. It's been quite an interesting ride since we first had these care management codes reimbursable back in 2014. And certainly providers have struggled to alter processes, identify appropriate staff, find the right technology solution to implement these processes. It is a commitment of resources to provide these care management services, to extend your service offering beyond the four walls of the hospital, the four walls of your clinic. And many folks that I think started early on looking to pursue this opportunity probably became discouraged and decided it wasn't worth the available reimbursement. What we have seen is some providers who have committed to the efficiency necessary to make this work and have invested the time and the resources and now are beginning to see the turn where they have staff that has become efficient and can work with multiple patients over the course of a day and generate sufficient revenue to cover the cost of those services. If your goal is simply to increase practice revenue, investment in care management services is probably not the best strategy, but those are building the infrastructure that's absolutely essential to succeed under any type of value-based payment model. It's just CMS is now giving you through reimbursement, through fee-for-service reimbursement, that opportunity to capture new revenue that can fund that infrastructure, which is going to be critical to success. And I think that's staying exactly true now with these virtual care codes. They are relatively low reimbursements. There's going to be many instances where the reimbursement is not going to be sufficient to cover the cost of the equipment, but it will be an offset and certainly improve the care of that patient and reduce the total cost of care in the long run, which is where we're moving with these value-based payment models.
Thank you, Marty. Next question up is directed to Jean, but perhaps Marty has a comment as well, and that's about billing for behavioral health encounters. And is that different somehow, or what are the differences between that and other kinds of billing opportunities that you have?
So this is Jean, and I mean, some of that is going to be insurance specific. You know, there are certain managed Medicaid products and Medicaid products that still require spoken hub requirements. So, you know, you have to just be aware of that when you're seeing a patient that they're in, that you have those parameters set up. A lot of the more commercial insurances will allow you to see patients where they're at and be able to bill for that service. Also, once again, it's insurance specific, whether that can be, you know, if you're going to provide telepsychiatric services in an inpatient unit, some insurers reimburse for that and some don't. So it's really just, it's on a case-by-case basis often that we're looking. And it's also on a state-by-state basis because each state also holds different parameters that you have to be aware of.
Thank you, Jane. We've got time, I believe, for one more question, and there's a number of questions that have come in around the concept of being able to communicate with colleagues who are not part of your organization, either in the post-acute side, perhaps the ambulatory side, perhaps referral partners, even in the acute care space. Can you talk a little bit about how you're approaching that and the kinds of hurdles that you've been able to overcome?
Yeah. So it's sharing the love. So we share the love of Diagnotes with them. And so, you know, really when I think about it, it's just, like I said, we just had this communication with a large system, just meeting about how do we effectively communicate with you so the patient's getting what they need in the environment. And so we have a couple of our hospitals where they have given the Diagnotes, you know, you can use that for free, but we've given them access to that information, and we're just sharing that with them. They can't see anything else except what we have agreed to share back and forth with them, and it has really helped with that discharge communication. We've given access to our psychiatrists and our psychiatric nurse practitioners as well, to if there's maybe a quick question that they might have, and it's really helped with the conversations around the whole patient care. It's not a hard application to do and to figure out, and that's what's been really nice. I'd say probably some of our bigger hurdles are, really that individual trusts that they can, that they have to go through a lot of processes on their end and ferret it out on their end. And some systems can take up to 6 months for that approval on their end to take place.
Mike, how about you? We'll
Yes,
give you the last word here.
So we've actually done this as well. So what we made a decision that we were going to make it, we were going to give access to all physicians who are members of our medical staff who wanted to. And we felt like we could do that and not get into trouble with Stark and anti-kickback and all that. In some circumstances, we have other entities, so we've actually have an arrangement where we give them access to that, like our home health care company, for example, but we actually charge them for that. And some of the other offices, the physician offices, if they want their staff to have access to it, if it's a non-employed or non-practice we don't own, then we would charge them kind of a nominal fee for their staff to use it, so they could all be on that same platform. Also, in Indianapolis here, there's several other hospital systems who are on DiagNotes, and we have the ability, we haven't done it yet, but we have the ability to connect ourselves to the other platforms through that DiagNotes relationship as well. So that's another way that can be approached.
Well, thank you to Dr. Fletcher, to Jean, to Marty. I hope all of you who are attending the webinar found it to be informative and enjoyable. We certainly appreciate you spending a part of your day with us. As I said earlier, we'll be happy to address the myriad of questions we've received that we did not have time to get to after the webinar is over. Of course, the recording of the webinar will be up on the Becker's website. And with that, this is Dave Wortman. Let me say thanks to all of you on behalf of my team at DiagNotes, and I'll turn things over back to Maggie.
Great, thank you, Dave. And to echo that from Becker's, thanks so much to Marty Ross, Jean Scallon, and Dr. Mike Fletcher, and also to Dave Wortman and DiagNotes. It was really a fantastic presentation today. And thank you to our audience for participating. That concludes today's webinar. So please enjoy the rest of your day, and we look forward to having you join us for future webinars.